This is a video for robotic right nephrectomy with autotransplantation with renal artery and vein reconstruction. The patient is a 33-year-old female with a history of cervical cancer. She received pelvic radiation and developed a pretty high-grade ureter stricture. The plan was to remove the right kidney and to auto-transplant it in the pelvis. This slide showed the port placement for the nephrectomy portion, and then three additional ports were added for the implantation. Starts off by placement of the assistant port for mobilizing the liver for the right nephrectomy. The right colon is mobilized to expose the kidney. Here you can start to see the kidney, and the hilar dissection is carefully undertaken. IVC is exposed after cauterization of the duodenum. And then we continue dissection inferiorly to identify the ureter. The ureter is abnormally dilated and thickened. We dissect out the hilum more and identify the vessels. You can see a renal artery in the background. We continue dissection, exposing the renal artery and vein. Here we start seeing a smaller superior pole renal artery. In this patient, there were two right renal arteries. We mobilize length, circumferentially control the renal vein right at the junction with the IVC. Continue the dissection and you start to see the main renal artery, and then we continue inferiorly, getting additional length on the ureter. The kidney is then mobilized, lateral attachments are taken, and the kidney is medially rotated. Remaining attachments are taken down. You can see the superior pole artery and the renal vein, and then the inferior pole artery can be seen. Here the ureter is being divided just above the stricture, and the stent that had been placed previously is removed. And then the diseased portion is clipped. Now we start dividing the vessels after giving systemic heparin. This is the second renal artery that's divided, followed by the division of the renal vein right at the junction with the IVC. Ureter is divided last above the clip, completing the nephrectomy. Here's a view of the renal bed, kidneys taken out. In this particular kidney, the right renal vein was reconstructed using bovine pericardium patch to get some additional length. And then there were two arteries which were reconstructed at the back table in a fish mouth technique. The ureter also was quite short. These are again another view of the port placement, and then we move on with the implantation. Peritoneal flaps are created on the right side to expose the iliac vessels. Here the inferior flap is being mobilized and start to visualize the external iliac artery and the vein more medially. This dissection was a little sticky because of the history of pelvic radiation. We mobilized length on both the external iliac artery and vein. Test clamps on the external iliac vein, and then the kidney is placed. Position has been marked with the blue marking pen. Opening is made in the renal vein, iliac vein, and then the end to side renal vein to iliac vein anastomosis is performed. Suture used is 6-0 Gore-Tex. The reconstructed portion of the renal vein is anastomosed to the side of the external iliac vein. Here the back wall is being anastomosed first. And here the anterior wall of the anastomosis is then completed. You can see the reconstructed portion of the renal vein pretty clearly here. Anastomosis is completed. And then a bulldog is applied on the renal vein, and the bulldogs on the iliac vein are taken off and placed on the external iliac artery. And arteriotomy is made in the external iliac artery, and then the anastomosis is performed between the two reconstructed renal arteries and the external iliac artery. Same technique is used as the vein, with the reconstruction of the back wall of the anastomosis followed by the front wall. Sixogortex suture is again used. Anastomosis is complete. Renal vein clamp is removed, followed by the arterial clamps and restoring perfusion. You can see the two arteries. Kidney looks well perfused. It's retroperitonealized and the peritoneal flaps are closed. Ultrasound is typically performed to look at the flow. Here's the short ureter. Opening is made in the bladder. And then neocystoureterostomy anastomosis is done. Here, suture being used is vicryl, but PDS is now more routinely used because it handles a little better. In this case, it was a pretty big dilated ureter, so the anastomosis was fairly straightforward. Stent is being placed across the anastomosis, and then the remaining portion of the anastomosis is completed, completing the operation. The patient did well, had an uneventful recovery. Duplex showed good flow post operatively, and she went home on day 3 without any complications. Thank you.